This plenary session is a timely talk on the evolving role of surgery in ovarian cancer. Surgery has been a cornerstone in the management of these patients, and the therapy and the surgical therapy has been evolving because of finely tuned and well-conducted studies and also advances in the technology of surgery. And so our speaker is Dr. Dennis Chi. He's a named professor, Ronald Perelman Professor in Gynecologic Surgery, head of ovarian cancer surgery at Memorial Sloan-Kettering Cancer Center, and through Team Ovary, which is a first gynecologic oncology team in the USA dedicated to surgical outcomes in ovarian cancer. He has published over 250 publications in surgery for ovarian cancer. So please help me welcome Dr. Chi.
Thank you very much for that very nice introduction, and thank you for allowing me to speak today at this international meeting. Please let me know, is everything okay with the Zoom and the slides? Just to confirm? Yes. Okay. So these are my disclosures. Most of them involve stocks that I've been buying now that I'm an empty nester and I have time and a little bit of money to invest in the stock market. So when we talk about surgery in ovarian cancer, there's so many different areas in the natural history of ovarian cancer where surgery may or may not be indicated. Obviously, everybody knows about staging of ovarian cancer, taking out lymph nodes and omentum. That's really not what we're talking about today, or I'm going to talk about. I'm going to talk mostly about primary cytoreduction and how to maximize the surgical outcomes in that setting. In patients who don't have primary cytoreduction and who get neoadjuvant chemotherapy, then usually 3 or 4 cycles are given and then an interval debulking or interval cytoreduction is performed. Historically, we would do primary surgery, give chemotherapy, and then do a second look surgery to see if there was persistent cancer. And in situations where there was, or even if there wasn't, we would give maintenance or consolidation chemotherapy. That's out of favor now, and really we don't do very much second look surgery anymore. And then the natural history is that hopefully the patient, as many as 80 to 90% will go into the first remission. And if that remission lasts more than 6 months, that's called a platinum sensitive recurrence, at which time, depending on the number of sites of disease and where it is and the patient's performance status, et cetera, a secondary debulking may be considered. That has been a strong area of recent publications, and there are publications favoring secondary cytoreduction and others not favoring that. That again is not what I'm going to be talking about today, although I would like to put in a plug for my team that just published one of the largest, if not the largest, series of doing the 4th debulking for recurrent ovarian cancer. And then of course, if patients develop generally a malignant bowel obstruction that can lead to death, sometimes palliative surgery is indicated. So again, I'm really not going to be talking about all these. I'm happy to answer questions about them. Today, I'm just going to be talking about primary cytoreduction and how to maximize outcomes. And we're talking about doing cytoreduction for stage 3 and 4 ovarian cancer, not ovarian cancer that's spread to other pelvic structures, but those that are starting to evolve: the upper abdomen, the omentum, the paraortic lymph nodes, and other distant areas. We know historically that we do cure a lot of patients with stage 1 disease, but about a quarter or 28% of patients present with stage 1 disease. The majority, 2/3 or so, present with advanced stage disease, where 5-year survivals have been reported to be, and these are old reports, of less than 50%. Patients present with diffuse carcinomatosis and an abdomen oftentimes full of ascites, as you can see here. So when I was asked to give this talk, the parenthetical reason was that people wanted me to give the people who asked me wanted me to give a passionate defense of the gynecologic oncologist as a surgeon. Well, I think that after 25 years in the business, I think that's pretty much all I've done, is try to defend the fact that gynecologic oncologists are the ones who know most about ovarian cancer, and we should be the ones who are doing the surgery. However, if we don't watch out and if we just try to give everybody neoadjuvant chemotherapy, do robotic assisted debulkings, then give chemotherapy and PARP inhibition, even though it may or may not work. And we lose our battle of trying to put a stake in the idea that we are the ones who should manage these patients surgically. Then there are other subspecialties that will do just as good, if not better, a job than we do if we don't understand that operating on ovarian cancer is not just a hysterectomy. Anyway, this is the outline of my talk, where I'm going to talk about optimal cytoreduction rates, expert centers, the fact that ovarian cancer doesn't care who's doing the surgery. It's going to go where it wants to go, and it's going to frequently go to the upper abdomen. And if you do more aggressive surgery or more comprehensive surgery, does that make a difference? And starting with that first topic, this is the evolution of ovarian cancer. And I put the framework of the evolution pretty much when I started fellowship in 1994 to 1997. There was the classic seminal work by Griffiths that showed that the less tumor that was left after surgery, the better the patients did. And even back then, patients who had zero gross residual disease did the best. But of course, this could be early stage disease, and those with diffuse metastatic disease, Griffiths didn't necessarily go after. But one thing has stood the test of time is the fact that there is a threshold that you need to cytoreduce the patient, or else you're not going to help the patient. In other words, if you take out all the tumors, but you still leave 5 centimeter tumor masses or 10 centimeter tumor masses, or even 3 centimeter tumor masses, it doesn't really matter. If those residual tumor masses are that big, it doesn't matter whether you leave 2, 3, 4, 5, 6, 7, 8, 9, 10 centimeter tumor masses, the survival is going to be poor, and you're not really going to achieve a benefit of cytoreduction. The goal of cytoreduction has changed over time, and this is where it was when I was training as a fellow. The goal was less than 2 centimeters or greater, and this is Dr. Aberustin, who was the chief at Memorial Sloan-Kettering of the Gynaecology service, and this was us at a meeting in upstate New York, where we were taking a rowboat after the meeting. This was the textbook that was published way back then. We're already on the 8th edition now. And I point this out to show you that, well, if optimal cytoreduction is the goal of surgery back then, we got a good result with surgery and optimal cytoreduction, less than 1 or 2 centimeters, however the author described it, less than half the time. That's pretty bad odds. If you go to a center and you want the cancer taken care of, and they only have a 1 out of 3 chance that they're going to get even less than 2 centimeter residual disease, pretty poor. And that's because this is what I was taught as a fellow. When we did radical ovarian cancer debulking at a major cancer center, it included doing an omentectomy. That was it. If we took the omentum out and we got all the disease out, it was an R0 resection. If we took all the omentum out and there's 1 centimeter disease left behind, the residual disease was 1 centimeter. We weren't doing, way back in the 1990s, the kinds of surgeries that we're now doing. Just as a historical reference, this is the first review article I wrote way back in 1996 with Dr. Hoskins. It was for something called the internet. I think a lot of us know what the internet is now, but at the time I was wondering, wow, what is this internet? Why am I writing this article, and who's going to read it? Interesting. Times have changed. Getting back to the present, if you look at worldwide results, ovarian cancer affects 200,000 women per year, 125,000 deaths. In America, it's the 5th leading cause of female cancer death behind lung, breast, colon, and pancreas. As I stated before, the majority of patients present with advanced stage disease, where long-term survival is less than 50%. But the reason why I'm showing you this slide is am I unmuted now?
No, we can hear you. Yeah, we can hear you.
I'm sorry, I'm just moving around the thing and I accidentally muted the sound. So the reason why I show this is that based on numerous studies, there's certain prognostic factors that improve or decrease a patient's survival. But the only thing that we can really change as surgeons and as doctors, yes, you can give the right chemotherapy, but that's pretty textbook, that's pretty cookbook. The only thing that we have an impact on is how much residual disease is left after the time of surgery. Everything else is either already predetermined before the patient even comes to see us, like their tumor grade, their age, their performance status, in some ways the stage. And this is the only thing that we can affect. So my good friend Rob Bristow published this meta-analysis a long time ago, way back in the early 2000s. And what he showed was that in looking at over close to 7,000 patients in 81 patient cohorts, what he studied was how many patients had an optimal or maximal side reduction in that particular study. Was it 20%, 30%? And in studies where the median, the optimal side reduction or maximal side reduction rate was 25%, the median overall survival was in the 24-month range. There were studies that had optimal side reduction patients up to 100%, but as I'll show you, those are chemotherapy papers. And basically what he tried to show was that if you were an expert center, then theoretically you would optimally side reduce patients 3/4 of the time. If you were a less experienced center, it was 25% or less. But in going from one center, a less experienced center, to a more experienced center, you would increase the median overall survival by 50 months. But the problem was this was a theoretical idea, because at that time, way back in the early 2000s, other than Scott Eisenkopf from California, there was no center that was proclaiming, publishing that they had optimal side reduction rates of 75% or greater, except the Buffalo with Piver, but they use an old cutoff of 2 centimeters to say that they were optimally side reduced. The rest were just chemotherapy studies where they studied optimal side reduced patients and they give them Cytoxan platinum chemotherapy versus cap chemotherapy. So the inclusion criteria in these chemotherapy studies was that they had minimal residual disease. But in those studies that were enriched for good surgical outcome patients, yes, their outcomes were the best in Bristow's study way over here, because they were all optimally side reduced patients. They were chosen for the study. So looking back in 2001, around that time, how were we doing at Memorial Sloan-Kettering Cancer Center, which is very typical of how surgery was done, with standard techniques of TAH, BSO, omentectomy, maybe a bowel resection here or there, maybe pluck some tumor here or there. But our optimal side reduction rate, defined as less than 1 centimeter, was only 25%. So during the early 80s and 90s, we were a less experienced center. So Woodrow Wilson, one of the ex-presidents of the United States, said, if you want to make enemies, try to change something. And I did try to change something, and I made a lot of enemies. But it is what it is, and I do believe that what we were doing at Memorial Sloan-Kettering made sense. It was logical. So if you are operating on somebody with ovarian cancer, you should probably be able to take out disease from the upper abdomen. We, as pelvic surgeons, as gynecologic oncologists, we're pretty good at doing exenerations, a posterior exoneration for ovarian cancer in the pelvis. But what about the upper abdominal disease? Well, we studied this in 2007. Our international fellow, Oliver Zavanovich, looked at 474 patients, not stage 4, but just stage 3C patients, who we operated on from 1989 to 2005. And what he found was that based on the operative notes, we found disease very, very frequently above the omentum on the diaphragm, spleen, liver, stomach, as much as 40% of the time. Sometimes the disease was less than 1 centimeter, and we can quote unquote call them optimal. But the majority of the time, there was disease in the upper abdomen, which at that time, from 1989 to 2005, we didn't necessarily go after. And this was not just us at Memorial Sloan-Kettering Cancer Center. Scott Eisenkopf published this paper in the early 2000s, a survey of the SGO membership, the American Society of Gynecologic Oncology, and with a very good response rate, 85% of respondents said, yeah, patients get suboptimal side reduction because they have disease in the upper abdomen, on the diaphragm. That to me is unresectable way back in 2001 based on this SGO survey. Other disease involving the base of the mesentery, the portal triad, was thought to be unresectable. So starting around 2001, around all this time, we started operating with our liver hepatobiliary service. Dr. Jarnigan, Dr. DiMatteo, they were liver surgeons, and we would call them in to help us, to learn and to help our patients get optimally side reduced, take out the spleen, a piece of the pancreas, the diaphragm, the liver. tumor from the portohepatis, gallbladder, as needed. We didn't do it on every patient, but if we found disease in those areas, we would call for help to see if we could get it out safely, and we did. So before we decided to do this multidisciplinary surgical approach was what I grouped as group 2, and then we compared it to patients who we had used standard techniques, maybe with a modified posterior generation. Although this difference in time, much of the patient characteristics and clinical characteristics were not any different. But by incorporating upper abdominal surgery, we were able to improve the optimal side reduction rate to 76% from 50%. That was statistically significant without really increasing our complications. But just because I say, you know as well as I do, all of you are surgeons, I said I got all the cancer out, but does it really matter if you got it all out? What we want is we want that patient to do better, have a longer progression-free and overall survival. So in God we trust, but the rest of us mortals must bring data. So does higher optimal side reduction rates, incorporating upper abdominal surgical techniques, translate into better survivals? That was the next paper. And so using that same cutoff point, but extending it to 210 patients over 4 years and comparing it to 4 years of 168 patients from 1996 to 1999. Remember, we changed in the later period. So we used extensive upper abdominal surgeries about 40% of the time, just what you would expect based on Zivanovich's analysis of disease in the upper abdomen, 40% of these patients. We improved our optimal side reduction rate from 46% to 80%. Now, this is optimal side reduction less than 1 centimeter, not complete gross resection. And we significantly improved overall survival. And you say, well, there's better chemotherapy in 2001 to 2004. Well, these patients had 1 primary debulking, had Taxol platinum 6 cycles of chemotherapy, and then we followed them. And the progression-free survival in those patients who had better surgery was double that of those who had the standard TAH-BSO omentectomy, pluck tumor here and there. So this is where our survival was with the standard surgery of 25% optimal side reduction, median survivals in the 30-month range. Around the 1997 to 1999, when Dr. Aberustam and I were fellows and graduated fellowship, and we started being more aggressive in the pelvis, we did improve the results in the pelvis and got median survivals in the 40-month range. But by incorporating upper abdominal surgery into our surgical armamentarium, we significantly increased our overall survival from the 40s to the 50s. And it wasn't just us at Memorial Sloan-Kettering that were doing that. The Mayo Clinic did a very, very similar performance improvement of their service, and they showed the same thing. More comprehensive surgery leads to better surgical outcomes and better survivals. In Italy, Peretti and Maggioni and the group in Milan published the same thing, the same kind of things. Distal pancreatectomy, partial liver resection. They operate with a surgical oncologist or hepatobiliary surgeon, Roberto Biffi. Same exact thing. My friend Sang-Yoon Park in Korea did the same exact thing in South Korea. But he, in this paper, showed that you could do these procedures in elderly patients. And finally, the Essen group with Philip Harder and Andreas Dubois showed the same thing, the same trends. As you get more comprehensive at your surgical approach, your median overall survivals will increase. So another philosophical point, working hard for something we don't care about is called stress. But this has been one of my passions, is to work hard and improve survivals and improve surgical outcomes. And yes, push the envelope to where we feel, okay, that's enough. We don't need to do any more surgery. So as the fellows will say to me in the operating room, are we really going to go after that? Isn't that just scar, Dr. Chi? The reason why we needed to push the envelope further is based on very, very pioneering work by Scott Eisenkopf, who showed in 163 patients back in the 1990s that you could get a complete gross resection in up to 85% of patients. And that these patients will do better than if you leave them with the old optimal less than 1 centimeter residual disease. We showed the same thing not using the extensive upper abdominal surgeries, but in a group of patients that that were on both sides of our increased optimal side reduction, improved optimal side reduction rates with upper abdominal surgery. This spanned both time periods. We showed that complete gross resection was associated with a tremendously long median overall survival. The GOG did the same thing. They looked at their patients who had complete gross resection compared to less than 1 centimeter residual disease, compared to suboptimal greater than 1 centimeter. They showed the same thing, that you can have very, very long overall survivals, median overall survivals, if you can get complete gross resection. This has been comprehensively reviewed by Sukjang Chang from South Korea. And in the green are all the studies, single institution, randomized controlled studies, cooperative group studies. All of these studies point to the fact that the patients who live the longest are those who get the complete gross resection. A GOG study that looked at IP chemotherapy, same thing. Median overall survival of 110 months, which is very similar to our 106-month median overall survival. But the thing is, so how could we do this? How could we improve? We're already operating on the liver and the spleen and the pancreas. How could we do it? Well, our thinking was that maybe if you did those procedures and you had more time to pluck the tumors from the small bowel and everywhere else, maybe you would get a better result with surgery. And we analyzed this. This was not a very easy statistical study, but Ed Tanner, when he was a fellow, did this at our institution. He looked at 422 patients who had primary cytoreductive surgery after we started using upper abdominal surgery over a 10-year period. And what he found was that it didn't matter what time you started if all you needed to do was get the patient down to less than 1 centimeter residual disease. However, in patients who had what he described as an OR tumor index of 2, upper abdominal disease gets you a point, carcinomatosis gets you a point. So in patients who had upper abdominal disease and carcinomatosis, you need to start early if you want to get a high likelihood of complete gross resection. It kind of makes sense, but it is true. Whether you're in Singapore or New York City, you can get tired if you've been operating for 4, 5, 6 hours. You have a much better chance of going after all that tumor if it's 2 p.m. and not 10 p.m. So what else did we do at Memorial Sloan-Kettering to get our complete cytoreduction rates higher? Well, the Amplio system was developed by the Department of Surgery to identify outliers of suboptimal performance. It was originally started in the urology service to see what urology professors, attendings, had high positive margin rates for prostate cancers and poor survivals. And also the Mayo Clinic did something similar. We initiated this at Memorial Sloan-Kettering, where every gynecologic oncology surgeon saw their complete gross resection rates, complication rates, optimal side reduction rates, et cetera, et cetera. So we didn't penalize anybody. We didn't take away any money, but the motivation was, if this is you, you want this to be complete side reduction. You don't want this red line to be, for example, that you have the highest complication rate. So just by our inherent natural competitiveness, when we compare ourselves to others on the service, it kind of makes you more motivated to kind of do the best that you can and not think that you can get away with cutting corners. So just a few pictures to show what we've been doing now with the idea that time is of essence in the operating room. You don't want to take 24 hours to do a debulking. So over the years, while we started learning how to do these procedures from the hepatobiliary and general surgical oncologists, now at Memorial Sloan-Kettering, the majority of the especially the team ovary surgeons who operate on ovarian cancer patients, we do this ourselves, not because we want to be a macho surgeon, but because it takes time, and we don't have the time to wait for somebody to come in and say, oh, okay, I'll be there. I'm just doing a Whipple in the other room. I'll come and help you take out the spleen. In the meantime, we're losing time, and time is running out. And plus, we want to get all these big things out so we can pluck all the little 1, 2, 3, 5 millimeter tumors from the small bowel in patients with carcinomatosis. So this is what we do as GYN oncologists at Memorial Sloan-Kettering. This is an en bloc resection of the omentum, spleen, and transverse colon. This is resection of celiac axis adenopathy. This is reconstruction of diaphragm after full thickness resection, reconstruction with mesh. This is a partial hepatectomy with diaphragm resection. This is a cholecystectomy with portohepatis lymph node dissection, resection of tumor from the ligamentum venosum. All done by us GYN oncologists, not because I'm trying to show you how great we are, but I'm trying to show you that we need to start early. We need to get the patient completely side reduced before we do any reconstruction of the rectum, et cetera, when you're very, very tired, because that leads to complications like anastomotic leak. This was an analysis of GOG 114 and 172, where they looked at patients, optimally side reduced patients who got IP chemotherapy, the best group of patients. The median follow-up was 10.7 years, and IP chemotherapy was associated with a 23% risk of death. IP therapy enhanced survival in those with complete gross resection, but the complete gross resection rate was only 36 months. Nevertheless, the median overall survival in this enhanced group, optimally side reduced, got IP chemotherapy was 62 months. So that was better in that patient population than what we had reported with improved optimal side reduction rates of less than 1 centimeter by incorporating upper abdominal surgery. But that was many, many years ago. That was 17 years ago. This is one of the most recent updates as to where we are now in Memorial Sloan-Kettering with the goal of surgery, complete gross resection, but also taking into account that I gave a talk earlier today, believe it or not, in Germany. We have to be cognizant of the idea of it's great to do these great surgeries, but if the complications are so great or the patient is so frail that they never get on chemotherapy, we're not necessarily doing that patient any favors or prolonging her survival. So yes, we do incorporate neoadjuvant chemotherapy in situations where a patient can't tolerate a big surgery, or there's just disease in the bones, in the chest, somewhere that's unresectable. And so by using this more complete multimodality approach, our most recent overall survival is 72 months because we are going for complete gross resection, starting earlier, not getting as many consults, using the Amplio system. And maybe Avastin contributes to this, maybe not, don't know. But what about the neoadjuvant chemotherapy? You say you're using that frequently. Our neoadjuvant chemotherapy, we still are doing complete cytoreductive effort at interval debulking, and we don't do neoadjuvant chemotherapy on everybody, but it's still very respectable at 43 months. But the most important thing is that from 2008 to 2013, all patients, whether you had primary side reduction, it was optimal or suboptimal, neoadjuvant chemotherapy, and you had interval debulking, the median overall survival during this time period was 63 months, which was as good as the GOG optimal side reduced IP chemotherapy patients. So what are the conclusions and future directions? Over the past 3 decades, studies have demonstrated the benefits of surgery are inversely related to the amount of residual disease. In other words, less disease, better and longer survival. And the maximum benefit is attained when you get a complete gross resection. As the goals of surgery have changed, the role of surgery has evolved from predominantly a pelvic operation to a comprehensive approach to the entire peritoneal cavity and even the chest. We go where the cancer goes. The best overall outcomes are achieved when state-of-the-art medical therapy, chemotherapy, PARP inhibition, Avastin, is combined with comprehensive surgery. And that comprehensive surgery, I hope it will continue to be performed by GYN oncologists. But if not, if you're in a center where it's not, then generally, I think surgical and upper abdominal hepatobiliary surgeons, if you explain to them why we're doing what we're doing and the results, I think they're always willing to help out. By striving for continued improvement, we wrote a paper, it's called Kaizen at MSKCC and other centers. Optimal side reduction and complete gross resection rates have significantly increased over the past 3 decades, to the point where one of our most recent papers shows the median overall survival for those who undergo primary debulking is 72 months. In that same time period of 2008 to 2013, it's better now. Our complete side reduction rates are in the 75 to 85% range. But at least from 2008 to 2013, the 5-year overall survival, remember I told you earlier, it's less than 50%. Now, with this comprehensive approach, it's greater than 50%. What are our future directions? Team ovary was mentioned. Our most recent analysis, as I told you, our CGR rate is over 80%. We're standardizing our algorithm and our futile laparotomy rate is 5%. We were trying to maximize the value-based care, giving nutrition to our patients ahead of time, decreasing blood transfusion, decreasing infections, getting our patients out of surgery, trying to decrease our anastomotic leak rate. Stress is associated with poor outcomes after surgery, so we're trying to decrease patient stress at the time of surgery. We're also trying to give prehabilitation to elderly patients. These are all ongoing areas of investigation to further improve our surgical outcomes. We've completed our participation in the international trust study, so the whole idea of who should get primary debulking versus neoadjuvant chemotherapy will hopefully be answered. And one of the big trials we're involved in now is doing HIPEC at chemotherapy with Dr. Van Driel and the others from Amsterdam. I'd like to thank the organizers of this meeting, my fellow GYN attendings, and my beloved Team Ovary for all the hard work and passion that have inspired me and others to do this kind of work. Thank you very much.
Thank you, Dr. Chi, for your powerful defense. I would like to remind the audience that we do encourage audience participation, so please feel free to post your questions online. We do have some questions. One of them is from Dr. Joseph Ng. Dr. Chi, your experience is reflected in the experience of others who advocate for radical cytoreductive surgery. The big picture question is whether the resource and the morbidity poured into such surgeries are worth the modest improvements in survival. Could we not get the same or better outcomes with adjuvant treatments?
Well, I think that the trust study will go a long way to answer that question. I frankly believe that the improvements in overall survival are more than modest. If you're looking at median overall survival is in the 72-month range, and if you look at the results of median overall survivals for neoadjuvant chemotherapy, I showed you ours is 43 months, but if you look at a lot of studies, the median overall survivals for neoadjuvant chemotherapy is in the 30-month range. It's almost never above 40 months. So I would make the argument that 2 years going from 40 to 70 months is 2 to 3 years. I do think it's worth the effort because while yes, the operations may be longer and the postoperative complications may require some diligent effort to take care of them, that's one hospitalization. When you're talking about resources and giving somebody 16 months or 18 months of Avastin or 2 years of PARP inhibition, I think that's kind of a drop in the bucket as far as resources go compared to the cost of those drugs that everybody thinks is the answer. And in addition, as far as PARP inhibition goes, not if you're a BRCA negative, HRD negative patient, your results with the PARP inhibition are not nearly as good as they are if you have a BRCA mutation. So I don't think that giving everybody PARP inhibition or Avastin or drug therapy for 3 or 4 years is as cost effective as one good operation.
Sure. I wanted to ask you, what is the role of systematic lymphadenopathy, lymphadenectomy for ovarian cancer? Has it evolved? Has it changed your practice?
I think, to be honest with you, I think my strength is common sense. I know that a lot of people, I remember reviewing papers from Europe, how people would say, even though I didn't get an optimal side reduction, I did a complete pelvic and perioperative lymphadenectomy, and those patients did very well. But I left large volume disease behind. In our institution, we always just took out enlarged lymph nodes. We focused on the intraperitoneal disease, and if the lymph nodes were enlarged, then we would take them out. And that's precisely what happened in the Lions trial, because there were so many centers that were so adamant about doing a systematic lymphadenectomy. The Lions trial, I think, definitively answered the question. If you have enlarged lymph nodes, yes, remove them. But if lymph nodes look normal, taking out normal lymph nodes does not add to the overall or progression-free survival. It just adds to complications.
I suppose, I suppose what happens at our tumor boards is for clinical stage 2 ovarian cancers, we kind of ding-dong a little bit about whether doing lymphadenectomy could upstage and then change the course of therapy. What do you think about that?
Oh, sure. That's different, though. That to me is lymphadenectomy for staging. Yes, I believe that patients should have lymphadenectomy for staging. I'm taking out normal appearing nodes to see, are they truly surgical stage 1 or 2, or are they 3 or 4? I believe in that, but what I'm saying is that if you have somebody with advanced intraperitoneal disease, you don't need to take out negative normal appearing lymph nodes.
We only have 3 more minutes for questions, but there's quite a few more. Did the surgery change over COVID? Did y'all do less primary 10-hour surgeries, or then y'all did interval debulking? How did it change anything for you guys, or not at all?
I think it may have changed a little bit. We may have not been able, for 2 weeks, we didn't operate at all. Oh. So if I had patients, I don't remember exactly, but if there was somebody who's going to have a primary debulking and I flat out couldn't operate on her for 3 or 4 weeks, then we had to give them neoadjuvant chemotherapy. But thank God, except for 2 or 3 weeks at the initial shutdown, we haven't really had a problem with our primary debulkings. I know other places have, and I'm very, very sensitive to the idea. I know that at Memorial Sloan-Kettering, we can do these big operations. We have ICUs, consultants, great anesthesia, other people to help us. I do realize that not every place can do the kinds of surgeries that we do at Memorial, but I think that if you can't, that's fine. But the idea that well, there's tumor on the diaphragm, it's too dangerous to remove. It's really not that hard. If you were stripping peritoneum from the pelvis, what's the only difference is you just need to know the anatomy of the upper abdomen. It's still peritoneum, whether it's on the diaphragm or on the bladder. It's the same thing. It's the same technique. So, I mean, to say that disease in the upper abdomen is unresectable because it's too aggressive and associated with too much morbidity is in my mind, not actually true.
We have a question from the floor.
Hi, Dr. Chi. I'm Clara May from National Cancer Center, Singapore. Thank you for the really great talk. And I think everybody knows that your name is synonymous with pushing the boundaries for optimal cytoreduction in ovarian cancer. I just wanted to ask you your thoughts on HIPEC for ovarian cancer. As we know, the Vandrel trial was published in 2018, and it did show some benefit for HIPEC in the primary debulking. Do you currently use that in the Memorial Sloan for the primary cases? And what are your thoughts about using HIPEC in the secondary recurrent cases?
Yes, so we are doing off-trial because it was a prospective randomized trial and published in the New England Journal of Medicine, and the NCCN guidelines, the National Cooperative Cancer Network, did say that it is an option to do. We at Memorial Sloan-Kettering are giving HIPEC at interval cytoreduction for patients who have stage 3 disease. We don't do it for those who have stage 4 disease initially. We're also participating in, there's a HIPEC trial by Vandrel at primary debulking. I'm very excited about it, but I'm not really thrilled about the fact that I'm going to do a primary debulking 6, 7, 8 hours and then have to add 2 hours of HIPEC. I don't know. I may not survive doing that. We published the paper recently in the Journal of Clinical Oncology, JCO. Dr. Zavanovich is the first author. Dr. O'Carroll is the senior author. A prospective randomized trial of HIPEC in the recurrent ovarian cancer setting. All patients had secondary cytoreduction. Then they had HIPEC or no HIPEC. Those who had HIPEC got 5 cycles of chemo. Those who had no HIPEC got 6 cycles. The overall survivals were the same. So you would say on superficially, well, that doesn't prove that, so that shows that HIPEC doesn't work. The problem was we fought a lot of political battles to get that trial up and running. For instance, we got 1 less cycle of chemotherapy in the HIPEC group. We may not have given the right drug. Maybe we should have given cisplatin or maybe carboplatin at a higher dose. So we're not giving up on HIPEC. We're still enthusiastic about it, but I wouldn't say that it should be done in the recurrent setting off of a trial. I would say the Vandrel trial is really good, and I can understand doing it in interval cytoreduction. But as far as primary or recurrence, I don't think the data is there yet.
Okay, we have one final question from the floor. Professor Jimmy So.
Hi, Dennis. Jimmy So, one of the organizers for this meeting, and I like your background. Nice meeting you online. Therefore, I'm a gastric cancer surgeon, and because of the aggressiveness of a gastric cancer with peritoneal metastasis, therefore our special interest is on developing intraperitoneal chemotherapy, and also lately pipette together with conversion surgery if the patient have a good response. So my basic question is a biology. I mean, in many primary cancer like gastric cancer or colorectal cancer with peritoneal metastasis, usually the prognosis are poor. But what makes ovarian cancer with peritoneal metastasis a difference? Look like is it a different biology or different embryologically is different that make the ovarian cancer with peritoneal metastasis seem to have a better prognosis compared to other primary? Thanks, Dennis.
Yeah, I mean, I think that both systemically and intraperitoneally, ovarian cancer is more sensitive to chemotherapy, specifically platinum-based chemotherapy. We have response rate for systemic chemotherapy of 80% with standard chemotherapy for ovarian cancer, which I don't think you have in colon or gastric cancer. I don't know the data on FOLFOX and FOLFIRI and things like that, number one. Number two, we have prospective randomized data that shows that intraperitoneal chemotherapy works. So the same drugs that we're using intraperitoneally, cisplatin and carboplatin and Taxol, we're doing at HIPEC. And like I said, I think that I do believe that intraperitoneal chemotherapy works. I wish that we hadn't gone away from intraperitoneal chemotherapy for this disease, because those 100-month median overall survivals, those were with intraperitoneal chemo. And so for some reason, because of Avastin and this trial and that trial, we've gotten GOG 252, 262, we've gotten away from IP chemotherapy, but I really believe it works. And the only way back, in my opinion, is showing that HIPEC works. And then maybe, that will lead some people to say, hey, maybe we dismissed IP chemotherapy too quickly for this disease where we were using it and it was effective for a couple decades. I think the problem with gastric and colon cancers, you just don't have drugs that are as effective systemically or intraperitoneally as we do for ovarian cancer. And the reason why is beyond my body of knowledge.
There are still several questions online, but we have to end the session. Thank you so much, Dr. Chi. That was wonderful.